on Drooling, Sialorrhea for ENT trainees and students with MCQ questions and answers. Start with this question on saliva production, true or false? Number 1, in healthy persons, the saliva production is about 1 to 1.5 liters of saliva per day. Number 2, 90% of the salivary production comes from the major salivary glands. Number 3, in the resting, the basal state, 72 of the produced saliva is secreted by the parotids. Number 4, on stimulation by meals, salivary flow increases twofold. Number 5, the stimulated salivary secretion is mostly from the parotids. Number 6, the adults would swallow to clear saliva once every minute while awake. True or false? Saliva production in healthy persons 1 to 1.5 liters of saliva per day. True. 90% of the salivary production comes from the major salivary glands. That's true. In the resting basal state, 70% of the saliva is secreted by the parotids. That's false. 70% of the saliva produced in the resting state comes from the submandibular glands, with a small contribution from the sublingual glands as well. Number 4, on stimulation, salivary flow increases twofold. False. On stimulation by meals or the smell of meals or even the thinking of meals, salivary flow increases up to 5 times. Number 5, the stimulated salivary secretion is mostly from the parotids. That's true. Number 6, the adults would swallow once every minute to clear the saliva while awake. That's true. Question on the acute presentation with sialorrhea. This can be caused by number 1, acute infections involving the mouth or the throat. Number 2, oral herpes simplex virus. Number 3, teething in children. Number 4, peritonsillar abscess, quinsy. Number 5, acute epiglottitis. Number 6, laryngopharyngeal reflux. Number 7, in sialorrhea, the acute presentation is commoner than chronic presentation. Answers for the acute sialorrhea presentation. Number 1, the acute infections involving the mouth or the throat. That's true. This can cause acute sialorrhea. Oral herpes simplex virus. That's true. This again can cause acute sialorrhea. Teething in children. It's true. Quinsy. That's true. Acute epiglottitis. That's also true. Laryngopharyngeal reflux. That's false. This will cause chronic rather than acute sialorrhea. In sialorrhea, the acute presentation is commoner than the chronic presentation. That's false. In fact, acute presentation is very limited in comparison to the chronic presentation with sialorrhea. Now to the etiology of chronic sialorrhea. Number 1, malocclusion. Number 2, macroglossia. Number 3, facial nerve palsy. Number 4, cerebral palsy. 5, Parkinsonism. And 6, paraplegia. The answers on the etiology of chronic sialorrhea. Number 1, malocclusion. That's true. This would limit the ability to seal the anterior part of the oral cavity. Macroglossia. That's true. This would limit the possibility of retaining some saliva in the oral cavity. Number 3, facial nerve palsy. That's true. It's also will prevent the tight seal of the anterior part of the lips and the mouth. Number 4, cerebral palsy. Again true. Inability to swallow the saliva produced at the same rate, and also inability to coordinate the movements to seal the anterior or the posterior part of the oral cavities. Parkinsonism. That's true. Again, inability to coordinate the movements required to seal the oral cavity. Number 6, paraplegia. That's false. Does not affect the production of saliva or its swallowing or its clearance posteriorly. Question on the drugs or the medications causing chronic sialorrhea. Number 1, lithium. Number 2, selenium. Number 3, atropine. Number 4, morphine. And number 5, amitriptyline. Which is true, which is false? Answers on the medications for chronic sialorrhea. Lithium, that's true. Selenium, it's again true. Atropine, that's false. If anything, atropine is used in the treatment of chronic sialorrhea because it would inhibit the release of saliva and its production due to the inhibition of the muscarinic receptors and the salivary tissue. Morphine, that's true. Amitriptyline, that's false. Again, amitriptyline may actually be used in the treatment of sialorrhea because it reduces the amount of saliva produced. A question on the medications used in the treatment of sialorrhea. The anticholinergic medications. Acetylcholine act at the salivary muscarinic receptors to produce saliva. Number 2, the anticholinergics have only few side effects. Number 3, anticholinergics are contraindicated in glaucoma cases. Number 4, in Parkinson's disease, the anticholinergics can block the muscarinic CNS receptors. Number 5, the glycopyrronium bromide, which is an anticholinergic, does not cross the blood-brain barrier. Answers on the medications in sialorrhea. Number 1, the acetylcholine act at the salivary muscarinic receptors to produce saliva. That's true. And the anticholinergics have only few side effects. That's false. In fact, the anticholinergics has very wide and sometimes very severe side effects that limits its wide use in the treatment of sialorrhea. Anticholinergics are contraindicated in glaucoma patients. That's true. In Parkinson's disease, they can block the muscarinic CNS receptors as much as they block the muscarinic receptors elsewhere, including the salivary muscarinic receptors. That's true. Number 5, the glycopyrronium, the anticholinergic. Glycopyrronium does not cross the blood-brain barrier. That's true. That's one of the major advantages of this medication in the treatment of sialorrhea. This is why it was chosen by the National Institute of Clinical Excellence as the first-line medication. Botulinum toxin injection in the treatment of drooling. Number 1, reserved for chronic sialorrhea due to neurological disorders in adults. Number 2, significant reduction in the unstimulated salivary flow rate. Number 3, it's contraindicated in patients with posterior sialorrhea and suspected aspiration. Number 4, it causes permanent inhibition of saliva production from the injected glands. Number 5 is injected only in the parotid glands. The answers for botulinum toxin injection. Number 1, it is reserved for chronic sialorrhea due to neurological disorders and in adults. That's true. Significant reduction in the unstimulated salivary flow rate. That's again true. It's contraindicated in patients with posterior sialorrhea and suspected aspiration. That's false. This is in fact one of the major indications in elderly patients who have posterior sialorrhea and suspected aspirations. Number 4, it causes permanent inhibition of saliva production from the injected glands. That's false. They cause inhibition only of saliva production, sometimes only partial, not total, and for a period of time around 6 months or so. Number 5, they are injected only in the parotid glands. That's false. They can be injected in one parotid, the 2 parotids, the submandibulars 1 or 2, or the 4 major glands, the 2 parotids and the 2 submandibular glands in resistant cases. The surgical management for sialorrhea. Number 1, the most common surgical option is the submandibular duct relocation. Number 2, the Wilkie procedure entails bilateral parotid duct retropositioning, relocation posteriorly, and bilateral submandibular gland excision. Number 3, the intraoral 4 ducts ligation. The 2 parotid ducts and the 2 submandibular ducts provides the best long-term control of sialorrhea. Number 4, surgery to denervate the salivary glands is performed through the middle ear. And number 5, denervation of the salivary glands works for between 6 and 18 months. Answers for the surgical management for Sialorrhea. Number 1, the most common surgical option is the submandibular duct relocation. That's true. The Wilkie procedure entails bilateral parotid gland relocation, parotid duct relocation, and bilateral submandibular gland excision. That's true. Number 3, the intraoral foreduct ligations provide the best long-term control. That's false. In fact, it only provides one of the least successful outcomes. The best possible long-term control of Sialorrhea is provided by the Wilkie procedure. Number 4, surgery to denervate the salivary glands is performed through the middle ear by tympanotomy to denervate the tympanic plexus and or the coda tympani sometimes. That's true. Number 5, denervation of the salivary glands works for 6 to 18 months. That's true. It takes only that amount of time for new neural connections to grow, or the salivary gland receptors becomes very or hypersensitive to any parasympathetic mediators in the blood. So that's true. By this, we come to the end of this presentation on the MCQ questions on drooling, Sialorrhea for ENT trainees and students. Assalamu alaikum.